Welcome to Unit 2. We've spent Unit 1 building the conceptual foundation, probabilistic thinking, Bayesian updating, cognitive biases, and measurement quality. Now we're going to get practical. This unit is about diagnostic test interpretation, the skills you'll use every single clinical day, and the skills that are tested heavily on the ACVPM exam. In Talk 1.2, we built our first 2x2 table and used it to count true positives, true negatives, and false negatives. In this talk, we're going to extract two of the most important numbers in diagnostic epidemiology from that table: sensitivity and specificity. We'll define them, calculate them, interpret them, and critically understand what they can and cannot tell you. By the end of this talk, you'll be able to build a 2x2 table from scratch, calculate sensitivity and specificity, explain what each one means in plain language, and know when to prioritize one over the other. Let's get to it. Let's rebuild the 2x2 table quickly, because everything in this talk flows from it. Rows represent what the test says, positive or negative. Columns represent what's actually true, disease present or disease absent. The four cells are true positive, false negative, and true negative. Here's the single most important structural thing to remember about sensitivity and specificity. They are calculated down the columns, not across the rows. Sensitivity is calculated from the disease present column. Specificity is calculated from the disease absent column. This is critical because it means sensitivity and specificity are properties of the test itself. They describe how the test performs in truly diseased and truly disease-free animals, respectively. They do not depend on prevalence. That's what makes them so useful for characterizing a test, and it's also what makes them insufficient on their own for interpreting an individual test result, as we'll see shortly. Sensitivity answers the question, of all the animals that truly have this disease, what fraction does my test correctly identify? It's calculated as true positives divided by all truly diseased animals, which is true positives plus false negatives. A highly sensitive test has very few false negatives. When it says an animal is negative, you can be pretty confident the animal really is disease-free, because a sensitive test rarely misses true disease. This is why a high sensitivity test is useful for ruling out disease. The memory aid, SNOUT, is worth memorizing. A sensitive test, negative result, rules out. This tells you exactly when to reach for a high sensitivity test, when ruling out a disease is your clinical priority. Examples of when ruling out is the priority: screening a population for a reportable disease, where missing a case has serious public health consequences. Ruling out lymphoma in a dog before concluding a lymph node is reactive. Testing a blood donor for infectious disease. One important caution: a highly sensitive test with a positive result is not necessarily a true positive, especially when prevalence is low. We saw this in Talk 1.2. The sensitivity tells you about the test performance in truly sick animals. It doesn't tell you the probability that a positive result in your specific patient reflects true disease. That depends on prevalence too, and that's where predictive values come in, which we'll cover in the next talk. Specificity answers the complementary question, of all the animals that truly do not have the disease, what fraction does my test correctly identify as disease-free? It's calculated as true negatives divided by all truly disease-free animals, which is true negatives plus false positives. A highly specific test has very few false positives. When it says an animal is positive, you can be fairly confident that animal really does have the disease, because a specific test rarely calls a healthy animal positive. This is why a high specificity test is useful for ruling in disease. The memory aid, SPIN, a specific test, positive result, rules in. Reach for a high specificity test when you need to confirm a diagnosis, when the consequence of a false positive is high. Examples of when ruling in matters: confirming a diagnosis before starting expensive, invasive, or risky treatment; confirming a positive screening test before delivering a serious diagnosis to a client; confirming disease status in an individual animal before depopulation decisions in an outbreak. Again, an important caution that mirrors what we said about sensitivity. A highly specific test with a negative result does not necessarily mean the disease is absent, especially when the pretest probability is very high. If your clinical suspicion is strong, a negative on even a fairly specific test might just be a false negative. This is why you always interpret test results in the context of pretest probability. Let's work through a complete example from scratch. We're testing 200 puppies for canine parvovirus using a fecal ELISA. Our gold standard, the true disease status, is determined by PCR. 40 puppies are truly infected, 160 are truly not infected. The ELISA has a sensitivity of 85% and a specificity of 92%. Step 1. Set up the column totals. Disease present equals 40. Disease absent equals 160. Step 2. Apply sensitivity to the disease present column. Sensitivity is 85%, and there are 40 truly infected puppies. 85% of 40 is 34, so true positive is 34 and false negative is 40. Minus 34 equals 6. Step 3. Apply specificity to the disease absent column. Specificity is 92%, and there are 160 truly uninfected puppies. 92% of 160 is 147.2. We'll round to 147. True negatives equals 147, and false positives equals 160 minus 147 equals 13. Step 4, check the math. True positives plus false negatives, 34 plus 6 equals 40. Check. True negative plus false positive, 147 plus 13 equals 160. Check. Step 5, verify. Sensitivity equals true positive divided by true positive plus false negative. 34 divided by 40 equals 0.85 or 85%. Specificity equals true negative divided by true negative plus false positive. 147 divided by 160 equals 0.919 or approximately 92%. Check. Now we have a fully populated and verified 2x2 table. From this table, we can calculate not just sensitivity and specificity, but also predictive values, which we'll do in the next talk. Get comfortable building this table because you will use it constantly. So far, we've treated sensitivity and specificity as fixed properties of a test. But for mini-test, any test that produces a continuous numerical result, sensitivity and specificity are actually adjustable, depending on where you set your cutoff value. Think about blood glucose. You choose a threshold, say 200 milligrams per deciliter, and call anything above it diabetic. But you could have chosen 180 or 220. Every choice of cutoff produces a different sensitivity and specificity pair. This is where the ROC curve comes in. ROC stands for Receiver Operating Characteristic, a name from signal detection theory that we don't need to worry about. What matters is what the curve shows you. Sensitivity on the y-axis against 1 minus specificity on the x-axis, plotted for every possible cutoff value. The top left corner of the graph represents the ideal test, 100% sensitivity and 100% specificity simultaneously. A curve that hugs that top left corner belongs to an excellent test. The diagonal line from bottom left to top right represents a test with no discriminatory ability whatsoever. It's no better than a coin flip. The AUC area under the curve summarizes overall test performance as a single number. A perfect test has an AUC of 1.0. A useless test has an AUC of 0.5. In practice, AUC above 0.9 is considered excellent, 0.7 to 0.9 is acceptable, and below 0.7 is poor. Choosing a cutoff is not just a statistical question, it's a clinical question. Do you want to maximize sensitivity because missing cases is costly? Move the cutoff lower. Do you want to maximize specificity because false positives are costly? Move it higher. The ROC curve lets you visualize this trade-off explicitly and choose the cutoff that best matches your clinical priorities. We'll return to this in Talk 2.4 when we cover test sequencing and the consequences of misclassification. Here's the fundamental trade-off that runs through all of diagnostic test interpretation. For most tests, especially those with adjustable cutoffs, you cannot simultaneously maximize sensitivity and specificity. Moving in one direction costs you in the other. This means choosing a test or choosing a cutoff for a test is always a clinical decision, not just a statistical one. You need to ask, what is the consequence of missing a true case? And what is the consequence of a false positive? If missing a true case is catastrophic, think blood donor screening where a false negative could transmit disease to multiple recipients, you want maximum sensitivity. You accept more false positives as the cost of missing no true cases. If a false positive would cause serious harm, think telling an owner their animal is positive for rabies exposure before recommending euthanasia, or making a depopulation decision based on a single test. You want maximum specificity. You want to be very sure that a positive result is real before acting on it. In practice, most clinical workflows handle this trade-off by using tests in sequence, a sensitive screening test first, followed by a specific confirmatory test. This gives you the benefits of both without the full cost of either. That's the topic of Talk 2.4, Test Sequencing Strategies. Summary. Sensitivity is true positives divided by all truly diseased. It tells you how good the test is at finding disease. Specificity is true negatives divided by all truly disease-free. It tells you how good the test is at clearing the healthy. Both are properties of the test itself and do not depend on prevalence. That's what makes them useful for describing a test performance. Snout and spin are your clinical decision rules for when to reach for each type. ROC curves let you visualize the trade-off when the cutoff is adjustable, and the AUC summarizes overall test accuracy. And choosing a cutoff is always a clinical decision driven by the relative costs of the two types of errors. In the next talk, we shift from test-level properties to patient-level properties, predictive values, which do depend on prevalence, and which are the numbers that actually answer the question your client is asking. What does this result mean for my animal? Pause the video and try to work through this scenario. We'll then work through it together. Let's work through all three questions. Question 1, build the table and calculate. Column totals, disease present equals 80, disease absent equals 420. The test correctly identifies 68 of 80 infected dogs. True positive equals 68. False negative equals 80 minus 68 equals 12. The test correctly identifies 399 of 420 uninfected dogs. True negative equals 399. False positive equals 420 minus 399 equals 21. The completed table looks like this. Test positive equals 68. False positive equals 21. Row total is 89. Test negative, false negative equals 12, true negative equals 399, row total equals 411. Column totals 80, 420, 500. Sensitivity equals 68 divided by 80 equals 85%. Specificity equals 399 divided by 420 equals 95%. Check. 68 plus 12 equals 80. Check. 399 plus 21 equals 420. Check. Question 2. In a shelter screening context, the veterinarian should prioritize sensitivity. The goal of screening is to catch as many truly infected dogs as possible to prevent transmission to other shelter animals. Missing a truly infected dog, a false negative, means that dog stays in the general population and potentially spreads Giardia widely. The cost of a false positive is lower. A dog gets treated unnecessarily, which has cost but is not catastrophic. Remember SNOUT, a sensitive screening test, when negative, gives you confidence the dog is truly uninfected. Question 3. Switching to the higher sensitivity cutoff, 95% sensitivity, 80% specificity means you now correctly identify 95% of 80 infected dogs equals 76 true positives, up from 68, and only miss 4, down from 12. That's a real gain in a shelter setting where transmission prevention is a priority. However, specificity drops to 80%. 80% of 420 uninfected dogs equals 336 true negatives, meaning 84 false positives, up from 21. In a shelter with limited isolation space and resources, 84 dogs unnecessarily isolated is a significant operational burden. You've gained 8 true positives and generated 63 additional false positives. Whether this trade-off is worth it depends on shelter capacity, the cost of Giardia transmission, and the cost of unnecessary treatment and isolation. This is exactly the kind of contextual reasoning the ACVPM exam expects you to demonstrate.